Hello. Today we'll be talking about the health inequalities that Aboriginal and Torres Strait Islanders face and reviewing 3 successful strategies to overcome them. Some recognize that the Australian Aboriginal culture is the oldest continuous culture in the world. However, community elders have said that the future of their culture is at jeopardy if the health inequalities that they face continue. Aboriginal and Torres Strait Islanders have higher death rates and die younger compared to non-Indigenous Australians. High rates of suicide and significant burden of disease from chronic illness contribute to the life expectancy gap between the two populations. The health and well-being of human beings and communities is determined by a combination of factors. The World Health Organization recognizes an individual's determinants of health to include the social and economic environment, the physical environment, and personal characteristics and behaviors. Health determinants can have a positive or negative impact on an individual's health. Although some can be attributable to an individual's personal choices or behaviors, such as dietary patterns or exercising habits, others can be completely out of their control. That is, access to safe water and social support networks, clean air, or genetics. As public health professionals, we are interested in those that are subject to intervention and that can contribute to public health strategy. In 1948, the WHO defined health as not only the absence of disease, but the complete physical, mental, and social well-being of an individual. However, the interpretation of good health is subject to change from one country to another, from one community to another, or even from one individual to another. There is no one definition of health within the Aboriginal community in Australia, yet there is a common agreement that health must be approached in a holistic manner. In addition to the WHO's definition in recognizing the importance of physical and social well-being, Aboriginal health includes the emotional and cultural well-being of the whole community, in which each individual achieves their full potential as a human being and therefore contributes to the total well-being of the community. Incorporating culture into Aboriginal health is key to the holistic approach. It is not only a matter of being culturally sensitive, but rather acknowledging the profound role that culture and land play for Aboriginal and Torres Strait Islanders. Health delivery cannot be separated from cultural beliefs and practices, and it must be understood that the community is at the core of Aboriginal health. Aboriginal health also includes a whole-of-life view. A cyclical notion of life, death, life means that in order to understand the present, the past must be reviewed. In this way, explaining present health conditions is done by linking back to an individual's or even a community's past. Within the same country or even community, there are factors that contribute to create health inequalities, that is, systematic differences between population groups. Evidence shows that social factors like education, employment, or ethnicity contribute to inequalities and that they are directly linked to an individual's socioeconomic status. A lower SES means a higher risk of poor health. Health inequalities exist between Aboriginal and non-Indigenous Australia. In 2010, the life expectancy gap between Indigenous and non-Indigenous Australians was approximately 10.6 years for men and 9.4 years for women. Moreover, approximately 80% of the mortality gap between people aged 35 to 74 years is due to chronic disease. Between 2011 and 2014, Indigenous children aged 1 to 4 were more than twice as likely to die than non-Indigenous children. Same is the case with maternal deaths. 3 strategies that aim to reduce the health inequality gap between Aboriginal and Torres Strait Islander and non-Indigenous Australians will be reviewed. Aboriginal community-controlled health services, alcohol restriction, and youth suicide prevention. As discussed, Aboriginal health is regarded in a holistic manner. Evidence shows that for a health intervention to succeed in an Aboriginal community setting, it is essential that the sense of community and cultural appropriateness be at the core of all health services. Aboriginal Community-Controlled Health Services, or ACCHS, are those that are initiated by local Aboriginal communities. The first Aboriginal medical service was established at Redfern in 1971, and to date there are more than 100 across Australia, with the aim of improving decent, accessible, effective, needs-based health services, as well as creating a sense of self-determination to the growing Aboriginal community. The centres have a primary healthcare approach. Jeannette et al. Conducted an economic evaluation of a community-controlled midwifery program at Durrock AMS in Western Sydney. The program is over 25 years old and services a community of approximately 12,000 Aboriginal members. Before the implementation of the program, compared to non-Indigenous Australians, perinatal mortality in New South Wales was 2 to 3 times higher and maternal mortality was 6 times higher. Evaluation of the program was done in both a quantitative and a qualitative manner. Aboriginal women that gave birth at 2 hospitals in Western Sydney were asked to give their views on their experience. The qualitative approach, done through interviews and focus groups, revealed important information regarding users' views before and after the program was implemented. Compared to Aboriginal women who did not attend Durrock, gestational age of first visit, number of antenatal visits, and routine antenatal tests measures were all better. Quantifiable data prior to 1990 is limited, for which reason it is difficult to show differences in health outcomes. However, the value of the qualitative data that the study presents suggests that women who attended the program changed the way they made decisions regarding health services and enhanced their self-esteem and confidence. Many agree that excessive alcohol consumption represents a substantial health, social, and economic burden on a community, not only on those that engage in the practice. Alcohol has been linked to criminal and violent practices, as well as to other risky behaviors such as substance abuse. In Australia, alcohol is the second most preventable cause of drug-related deaths and hospitalization. For Aboriginal and Torres Strait Islander men between 15 and 34 years old, it accounts for the greatest proportion of the burden of disease and injury. This is not a recent issue. Since 1996, the Northern Territory Liquor Commission recognized the need for a public intervention and conducted a trial that included, among other things, strict restrictions regarding the availability and accessibility of alcohol in certain areas. The town of Tennant Creek is one of the most talked about and evaluated cases in which alcohol sales declined after the strict restrictions, particularly the Thirsty Thursdays clause, which banned alcohol sales completely on Thursdays, the day on which most Social Security entitlement wages were paid. Gray et al. Conducted an evaluation of the program. Evidence indicated that over the 2 years after the introduction of the program, there was a 19.4% reduction in alcohol consumption. Police records showed that a reduction in alcohol-related crimes, especially on Thursdays. An interesting result was that even though the restrictions were not well received at the beginning of the trial, when evaluating the program, the community showed support and was in favor of them. Some even wanted additional restrictions to be set in place. As a result of this evaluation, the NT Liquor Commission maintained the restrictions and other towns have followed them. There are several other study cases that evaluate the effectiveness of alcohol restrictions. Fitzpatrick talks about how in 2006, senior Aboriginal women in the remote community of Fitzroy Crossing, WA, personally took a stand to implement alcohol restrictions after alcohol was determined to be a contributor factor to a streak of over 50 deaths. Alcohol sales were reduced by 75%. Indigenous youth, 10 to 24 years old, suicide rose from 10% of total Australian suicide in 1991 to 80% in 2010. Within the Aboriginal community, self-harm is the third most likely cause of death for males and the ninth most likely for women. Every day, they are exposed to risk factors such as ongoing grief and loss, discrimination, family issues, housing and health concerns, comparatively low incomes, higher unemployment rates, and poor education outcomes. Elders of the Aboriginal communities have recognized that the future of the Aboriginal culture is at risk if the current situation continues. An early intervention program was put in place in the Shoalhaven region in New South Wales to combat high youth suicide rates. After extensive consultation with the Aboriginal community, several culturally appropriate interventions were developed. The main focus was to deliver community gatekeeper workshops. The study reports increased levels of knowledge about suicide prevention, confidence in dealing with a suicidal person, intention to help, and to refer to mental health services. These results can be seen as a key tool for members of the community to timely identify and refer to the appropriate services people who might be at risk of self-harm. The study highlights the importance of developing culturally appropriate mental health services that the community can trust and relate to. Overall, the strategies reviewed had one main theme in common: extensive community consultation and involvement. Because of the high need for self-determination within the Aboriginal community, it is key for any intervention program to bear in mind the concept of holistic health and to have at its core the values and culture of its members. Thank you.